Good evening, everyone. So thank you for joining me today. So today we're going to talk about atrial septal defect. So the aim for this talk today is really to make you understand the embryological development of atrial septal defect, for you to easily differentiate between four types of atrial septal defect, and for you to recognize in echocardiogram how do you detect atrial septal defects. So the only true atrial septal defect, meaning that the only true ASD that is the defect just at the interatrial septum, is the secundum atrial septal defect. Now the other three atrial septal defects, for example, in primum atrial septal defects, the defective wall is actually the atrioventricular connection. I will show you a little bit later what do I mean by that. In sinus venosus ASD, so this is the third type of atrial septal defect. The deficiency is actually not the atrial septum, but it's actually part of the shed wall between either the superior vena cava in the case of superior sinus venosus ASD, or inferior vena cava in the case of inferior sinus venosus ASD with the left atrium. In unroof coronary sinus, it is actually because of deficiency of part of both posterior wall of the left atrium and the coronary sinus itself. So if you were to remind ourselves, so coronary sinus is actually the vessel that actually accept blood from that drain blood from the coronary arteries. So the coronary sinus is actually caused at the back of the left atrium, and it actually drain into the right atrium. So at the time when they cause at the back of the left atrium, they actually shed two walls. So the wall actually link together. So in patient with unroof coronary sinus, this shed wall between them is actually deficient, so that you actually have connection between the coronary sinus and also the left atrium. On all these four atrial septal defects, the most common one is secundum ASD, and only secundum ASD can be closed via transcatheter closure. So all the other three, you need to go for surgery. So let's go through some embryology, because this is very important for us to understand atrial septal defects. So when we look at the echocardiogram, and I have said this before, so the reason we say some chamber left atrium, or the reason we say some chamber right atrium, is not because of their position inside the heart or their spatial position inside the heart. So the reason we call left atrium is because its intrinsic morphological characteristics. In order to understand atrial septal defect, it is very important to understand the development of heart embryologically. So heart actually starts just as a single heart tube. So I will show you the single heart tube later, and this heart tube actually the one that is folded into different types of cavity. So the morphological right atrium developed from the right sinus venosus of the primitive heart tube. So I just wanted to show you so that you understand what do I mean by heart tube. So this is our primitive heart tube here. You can see it is a single structure like this. If you look at the primitive heart tube, it is divided into few parts. So the topmost part is the truncus arteriosus here. The bottom one is bulbus cordis. The bottom some more is ventricle. After that, the atrium, and then the sinus venosus. Okay, so it is important to understand that this region of truncus arteriosus will later develop the pharyngeal arch arteries. So 6 on the left side and 6 on the right side. So the left side, the arch number 4 will become the aortic arch, and the arch number 6 will become pulmonary arteries. So I won't touch on the other arches, but just remember that the truncus arteriosus is the one that is responsible to develop into the pulmonary artery and the aortic arch. Okay, so what about the bulbus cordis? So the bulbus cordis that sit at the bottom of truncus arteriosus, it actually become the right ventricle, the left ventricular outflow tract, and the right ventricular outflow tract as it develops. When we look at the ventricle, it actually will develop into the left ventricle itself. When we look at the atrium, this atrium will develop, so this primitive atrium will actually develop into left atrium, the left atrial appendage, and the right atrial appendage. And finally, that is your sinus venosus. So the left part of the sinus venosus will become your coronary sinus, and the right side of the coronary sinus will form the smooth wall of the right atrium. Okay, so to understand again, so this single structure then will look and specialize into different cardiac chamber. So this become the pharyngeal arch arteries. So this, the bulbous cordis, actually will become the right ventricle and the left ventricle and right ventricular outflow tract. Therefore, it is not surprising if the heart development is arrested before it fully matured. So for example, you can have situation in which you have both the pulmonary artery and the aorta coming from the right ventricle, a condition called double outlet right ventricle, because both of the structure actually just connected to the right ventricle at the early part of embryological development. So the other condition is a condition that is called double inlet left ventricle. So why can that happen? So if you notice, the ventricle, just this is the left ventricle, both of the atrium here only open on a single left ventricle at the beginning of embryological development. Okay, so therefore, if it's arrested before the development is complete, you have also a possibility to have another condition that is called double inlet left ventricle. So this is all by understanding of embryological development. So this is your truncus arteriosus, that is your bulbous cordis and develop in becoming right ventricle, and that is your left ventricle. So if you notice, the part here at the bottom, sinus venosus, will actually loop and fold it and go up like this. Okay, this will fold and go up to the other side. So this is what we call the looping of the ventricle. So the ventricle can loop. In a normal looping, it is what we call a D-loop ventricle, in which the left ventricle continue to be the left side and the right ventricle continue to be in the right side. However, there is an abnormalities in embryological development in which you can have an L-loop ventricle, in which the ventricle swap place, so that the left ventricle on the right side and the right ventricle on the left side. So that is called L transposition of great arteries. So when they have looping, so this is the final configuration. So as you can see here, you have left atrium that come from the primitive atrium, the right atrium that you come from the right sinus venosus, the left ventricle that come from the primitive ventricle, the right ventricle and the right ventricle and the left ventricle outflow tract that come from the bulbous cordis, and the aortic arch and the pulmonary artery that come from the truncus arteriosus. Okay, so this is how the heart developed during our embryological development. So I hope you understand that. Now, what is the inner characteristics of the right atrium and left atrium when we look at the echocardiogram before we decide that is the right atrium or left atrium? So in the left atrium, the first thing, the appendage is finger-like and it have narrow base. Number two, the septum that is facing the left atrium is always the membrane primum. Number three, the pulmonary vein should incorporate into the left atrium. Number four, the pectinate muscle, the one that you can confuse like a left atrial appendage clot, is always confined into the left atrial appendage itself, compared to the morphological right atrium. So it is a triangular appendage. It have a broad base. The septum that is facing the morphological right atrium is the membrane secundum. Okay, it contributes the side of the interatrial septum. The IVC goes into the right atrium. And most importantly, the pectinate muscle in the right atrial appendage actually go outside the right atrial appendage. The left atrium and right atrium, mostly the left is on the left side and the right on the right side. However, there is condition where this inverted, so the morphological left atrium on the right side and the morphological right atrium on the left side. So this is what we call as situs inversus. Okay, so normally that is actually what goes with it is that the liver is also inverted. So rather than on the right side, it's on the left side. Okay, that is called situs inversus. There's also a condition called heterostaxy. So hetero is other and taxi is arrangement, so other arrangement, in which the both of the morphological atrium is the same one. So if you have both atrium is a morphological right atrium, we call it isomerism of right atrial appendage. So that is one type of heterotaxy. If both of the atrium is left atrium, we call it isomerism of the left atrial appendage. So left atrial heterotaxy. Now, I just wanted to tell you as well the embryological basis of something that is called co-triatriatum. So what is co-triatriatum? So co-triatriatum is actually a membrane inside the left atrium. Okay. So what happens is there is few things that can happen when your common pulmonary vein combine with the left atrium. If all the common pulmonary veins are unable to combine with the left atrium, you will have a condition called total anomalous pulmonary venous connection. Okay, and you cannot survive with that. If only part of it merge with the left atrium and some part don't merge with the left atrium, so what would you have is co-triatriatum. Okay, so if you go, the common pulmonary vein go into the left atrium, but the membrane that is divided, the two doesn't disappear, that is actually called co-triatrium, co-triatriatum. Okay, so that is how total anomalous pulmonary venous connection and how partial anomalous pulmonary venous connection happen. Okay, it is because of the fusion of this common pulmonary vein. There is another co-triatriatum that is called co-triatriatum dexter. So this is the membrane on the right atrium. However, in this situation, it is not a real membrane. It is not because of the failure of any structure to fuse with the right atrium. Rather, it is because of a big eustachian valve that is persist that look like a membrane. Okay, so that is a totally different thing. Co-triatriatum sinister on the left side and co-triatriatum dexter on the right side. So this is my my attempt, a very basic attempt on how to explain you the embryological development of the interatrial septum. So let's start with the box here. So this is the left ventricle, that is the right ventricle, that is the left atrium, and that is the right atrium. So something that I wanted to bring your attention is the ventricle always bring the tricuspid valve together. So the right ventricle always bring with itself tricuspid valve, and the left ventricle always bring itself the mitral valve. The tricuspid valve always attached slightly apical to the mitral valve. So this is more apical to the mitral valve. Okay, so if let's say you look at the echocardiogram and suddenly you see on the left side of the ventricle, the valve is attached more apically, then you know that the right ventricle has gone to the left side. Okay, so this is the correct arrangement. So left ventricle and right ventricle. Look at the different attachment between the mitral valve and tricuspid valve. Okay, so therefore, if you have hole here, you can actually have a shunt between the left ventricle and the right atrium, otherwise known as Grobody defect. So let's see the development of the interatrial septum. Okay, now the first thing that happened is that this red thing here is one of the membrane called membrane primum. So it's the structure inside the left atrium. So it actually go down to separate the left atrium into the right atrium. So this is the first thing that goes down. Now, at first, it doesn't go down all the way. Okay, so it stopped here for a while. So it leave a hole here that is called the ostium primum. Okay, that is called the ostium primum. Now, after a while, the ostium primum will close. Okay, if the ostium primum doesn't close, so what you have is your ASD primum. Okay, now when this membrane primum closed all the way, so what happened is you have an appearance of another hole on the top there. So that hole there is called ostium secundum. Okay, so membrane primum go down. At first there is a hole that is called ostium primum. If that hole doesn't close, you have ASD primum. Okay, if let's say the hole close normally, so it close after a while, you have a second opening. Okay, second opening literally mean ostium secundum. So you have ostium secundum here. So what happened after that? So look at the bottom part. Okay, so look at the bottom part. So what happened is, look at the green line. So the green line is actually membrane secundum. So membrane secundum is the structure on the right atrium. So membrane secundum will come from the top down like so, and it should cover the membrane primum here. Okay, so there should be any hole between the left atrium and the right atrium. So what happened during embryological development? So in embryological development, because the blood bypassed the lung, so what happened is you have a shunt between the right atrium bypassing the lung into the left atrium. So this is called the foramen ovale. So you go from here to here. So what happened after you were born? So after you were born, suddenly the pressure inside the left atrium is higher than the pressure inside the right atrium, so it pushes the flap and it closes the flap down. Okay, so this is the development of interatrial septum. So I repeat, first a membrane primum come down. So you have an opening here that is called ostium primum. If it doesn't close, you have ASD primum. The membrane primum then will go and close all the way, and later there will appear an opening on the top of membrane primum that is called ostium secundum, second opening. Okay, so if you look here, you will have a membrane secundum that will go down and close this ostium secundum. So this is a membrane secundum that close the ostium secundum. During inside your mother's tummy, you don't need the lung, so you have right atrial pressure that is higher than the left atrial pressure. So this is actually open the flap, so the flow is go from the right atrium to the left atrium to this pattern foramen ovale. However, as you were born, the left atrial pressure is higher than the right atrial pressure, so this will push this one. So what happens is that the flap close, okay, so that you will have an intact interatrial septum. Okay, so this is a normal development of the interatrial septum. However, if this flap is not very tight, so you can have a condition that is called pattern foramen ovale, and this happens in 25% of our population. So I hope you understand that. Number two, if let's say this hole here, what is called the ostium secundum hole, is so big, so that the membrane secundum is not able to cover it, you will have ASD secundum. Okay, so I show you the development of ASD primum and ASD secundum. I will show you a bit more later. So this is an example in transesophageal echocardiogram. So that is the left atrium and that is the right atrium there. So what you see here, so that is actually the membrane primum. So this is the left atrium and the right atrium. Okay, so if you can see here, there is a little bubble that coming to the left atrium when the patient is valsalvaing. So this patient have a small pattern foramen ovale. Okay, so right atrium, left atrium, and that is the membrane primum. When you look at fossa ovalis, the floor of the fossa ovalis is actually made of membrane primum. Right? Now, I will talk about the first type of atrial septal defect, the one that we call ASD primum just now. Okay. Now, ASD primum is actually part of a family. This family is called atrioventricular canal defect. So in this family, they share a single pathophysiological abnormalities, which is failure of the development of the endocardial cushion. Okay, so there is something that is deficient when the interatrial septum and the interventricular septum go and meet each other. Okay, so you have a deficient. However, you have few different type of atrioventricular septal defect. However, all of those have the same defect. So you have a same endocardial cushion defect. And the other thing that is important, all of them share a common annulus. So if you look at all the AVSD, all the valve attached at the same level. In normal people, the tricuspid valve attached more apically than the mitral valve. In patients with atrioventricular septal defect, all attached at the same place. As you can see here, the tricuspid and mitral valve attached at the same place. Same is here, and same here. So what is the difference between all these four? Okay, so this number one is what we call ASD primum. So what is ASD primum? So ASD primum is what we call partial AV canal defect. It is where you have only atrial level communication. So you only have communication between the left atrium and right atrium, but you don't have communication between the left ventricle and the right ventricle. That is what we call ASD primum. This is what we call transitional AV canal defect. Transitional AV canal defect. So what's the difference between this and this? Okay, the defects are the same. The defects are the same. The difference is the attachment or the position of this common AV valve. So this common AV valve is slightly in the middle. So what happens is that you have interatrial communication and you have a small ventricular septal defect. So you have an ASD and small interventricular septal defect. Exactly the same as this. The difference is only the attachment of the common AV valve. So this is what we call transitional AVSD. So this is a partial AV canal defect. This is the transitional AV canal defect. What's the difference between this and these two? Okay, that's not a lot. So the difference is again the attachment of the common AV valve. In this situation, you have a big ASD and also a big ventricular septal defect. The ventricular septal defect is big and non-restrictive. So this is what we call a complete AV canal defect. And about the last one, also the diffusion is the same. It's only that the common AV valve attached to the top of the interatrial septum, and you only have a ventricular level communication that is big. That is also a complete atrioventricular septal defect. So if you notice, all of these are the same in terms of embryological development. However, the only difference is where the valve attach. So if they attach to the interventricular septum here, you have ASD primum. Otherwise, you can have all the other three. The difference between transitional and complete is the size of the VSD. The transitional, the VSD is small, and in complete VSD, the VSD is big and also non-restrictive. So this is a spectrum of AV canal defect. So in patient with ASD primum, what happens is you can have a bridge across the left AV valve and the right AV valve. So this bridge on the left AV valve gives the appearance of cleft on the left side of the AV valve. So anyone that have ASD primum always look for concomitant mitral valve cleft. Okay. So in patient with partial AVSD, you have a bridge across separating the left leaflet and the right, so the left valve and the right valve. In patient with transitional complete AVSD, you don't have the leaflet. So what you have is a common AV valve. In patient with ASD primum, one of the main problem is that the aorta is unwedged from the left atrium, from the mitral and tricuspid valve. So you have a risk of left ventricular outflow tract obstruction because of the elongation of the left ventricular outflow tract. So I hope you understand now the basic of AV canal defect and what is ASD primum. So now I just wanted to show you so that you can understand what does the leaflet look like. Now, in patient with AV canal defect, the leaflet does not look like your typical left mitral valve and right tricuspid valve. So what happens is they share a common AV valve. So on the left side, so this is the left side, rather than a mitral valve, you have this one left mural leaflet. You have this superior bridging leaflet at the superior part of the common AV valve. You have this inferior bridging leaflet. Then on the right side, rather than tricuspid valve, you have the right anterior superior leaflet and right inferior leaflet. Now in ASD primum, because you have a bridge dividing the left and the right AV valve, so look at the left AV valve. So you have the structure in the middle here. Okay, that is what we call the cleft left AV valve. Okay, it is not a real cleft. It is just because the arrangement of the leaflet that cause it to be like so. This is a pathological specimen of ASD primum. As you can see, it is near down here at the endocardial cushion. And the defect is not just atrial septum, it is also of the ventricular septum. So it is a atrioventricular septal defect rather than just a pure atrial septal defect. Okay. So those of you that goes for exam, 80% of patients with AV canal defect have Down syndrome. They have associated abnormalities of cleft mitral leaflet, and I already teach you how that happened. Sometimes the leaflet is separated, the two valve is separated by a bridge, so you can have a left and right AV valve, and in complete AVSD, you have a common AV valve. Conduction defect is very common because the AV node is displaced inferiorly. In the ECG, sometimes you can see a first degree AV block, right bundle branch block with left axis deviation. So I just wanted to show you an example here. So this is a 3-year-old boy with ASD primum. So this is the left ventricle and right ventricle, left atrium and right atrium. As you can see there, there is the ASD primum there. Something that is very important to point you towards the direction of ASD primum is the fact that the right AV valve and the left AV valve is at the same level. In normal people, the right AV valve should be more apical compared to the left AV valve. So this is a subcostal view just to look at the relative size of the left ventricle and right ventricle. In adult, usually we don't do this, But in congenital patients, sometimes they can have a problem with the development of the left ventricle and right ventricle. So one of the ventricle can be hypoplastic. So this is a good view to look at the relative size of the left ventricle and also the relative size of the right ventricle. So let's go back to the parasternal long axis view. So something that is quite special with patients with ASD primum and AV canal defect in general is they have an elongated left ventricular outflow tract. Okay, what is the reason they're having an elongated left ventricular outflow tract? This is because the aorta is unwedged. The aortic valve is unwedged from the mitral and tricuspid valve in patients with AV canal defect. So whenever you look at parasternal axis view, just reassure yourself there is no left ventricular outflow tract obstruction. So the other reason is, of course, there is also a possibility that you have a direct attachment of chordae tendineae from the anterior mitral valve leaflet to the interventricular septum. That shouldn't happen in patient with normal heart, but this can happen in patient with AV canal defect. Okay, this is a parasternal long axis view. As you can see, the right ventricular is dilated. So one of the most important things about atrial septal defect is it causes right heart dilatation, as opposed to VSD and PDA that cause left-sided heart dilatation. So this is the view. So you can see the left ventricle, right ventricle, left atrium, and right atrium there. So as you can see here, you have red blood crossing from the left to the right side through the ASD primum. So this is actually a AOPA view. So that is the aorta there. That is the right pulmonary artery, and that is the left pulmonary artery there. So I just let it play. If you look at here, you can see a continuous flow at the branching of the left pulmonary artery there. So what is that continuous flow there? So this continuous flow is a pattern ductus arteriosus that connect the descending aorta to the left pulmonary artery. So it causes continuous murmur. And PDA is very important. Oftentimes, it is the only source of pulmonary circulation in patients with congenital heart disease. So therefore, in patient that is born with congenital heart disease, a lot of the time, they will be given prostaglandin to maintain the patency of this pattern ductus arteriosus. So this is a short axis view of the mitral valve. So that is mitral valve here. If you notice the mitral valve, it doesn't form a complete circle. In the top part here, there is a separation of the mitral valve. So that is the mitral valve cleft that I told you, simply because of the separation, because of the common left and common right AV valve. So you have mitral valve cleft, and this often can cause mitral regurgitation. So that's the left AV valve, and that is the right AV valve, and that is actually the mitral valve cleft in patient with ASD primum. So that is the first case of someone with ASD primum. So this is someone with complete AVSD. So you wouldn't get confused anymore, because I already teach you that a complete AVSD is just a variation of AVSD. So it's the same as primum ASD, but the difference is that you also have a big ventricular septal defect. And in this situation, you have a common AV valve. So let's look at the echo here. So parasternal long axis view look the same as the before. You can see that the right heart is dilated. So the right heart is dilated. So you have to find a reason why is the right side dilated all the time. So it can be because of ASD. So you have to find all the different type of ASD. Is it secundum? Is it primum? Is it sinus venosus? Or is it unroof coronary sinus? Now, if for unroof coronary sinus, usually you will see a dilated coronary sinus here, just at the adjacent to the basal infralateral wall. So there is no dilated coronary sinus there. Okay, so it is not unroof coronary sinus. So this is a subcostal view. Okay, so this is a left ventricle, that is a right ventricle. So again, we wanted to look for shunt. Is there any shunt that explains why the right heart is dilated? And lo and behold, you can see this shunt here. That is look like the ASD primum. You can see the shunt between the left atrium and the right atrium. So this is the left atrium, that is the right atrium, and that is the shunt there. Okay, but in addition, you also see shunt here at the ventricular level. So that's a shunt at the ventricular level. So one at the atrial level and what is the ventricular level. So you tell me, why is this not ASD secundum? So this is not ASD secundum because you don't have any atrial septum that is bordering in the inferior side. So you have superior border, but you don't have inferior border. So this cannot be ASD secundum. And the second reason is that the left AV valve and the right AV valve is actually at the same position. So that is again ASD secundum. However, In this patient, if you look at the top here, this is actually a concomitant ASD secundum. You see that? A small ASD secundum on the top here. So this is someone with complete atrioventricular septal defect with concomitant ASD secundum. So that is the ASD. That is the ventricular septal defect. So you look at the left ventricle, always decide whether the left ventricle and right ventricle is balanced in terms of the size. And the arrow that I show you there is actually atrial septal, so ASD secundum. You have complete AVSD with ASD secundum. If you look at the subcostal, looking at the valve unfast, so this is actually a common AV valve. So in this situation, because there is no bridge separating the left and right AV valve, what you have is a common AV valve. So common AV valve, if you remember, consists of superior bridging leaflet. So this is a little bit deep, okay? But for those of you who are interested, for complete AVSD, we actually can separate the complete AVSD via what we call a Rastelli classification based on how divided and where does the superior bridging leaflet divide. So if the superior bridging leaflet divide at the middle, that is called Rastelli A. So that is, this here is the superior bridging leaflet there. And you can see it divide in the middle, it's called Rastelli A. If let's say the superior bridging leaflet divided more on the right ventricle, more on the right side papillary muscle, that is called Rastelli B. And if let's say the superior bridging leaflet does not divide at all, it is free floating, it is called Rastelli A. So you don't need to worry about classification. So I just wanted to tell for those who are interested. The same thing here, if you again recognize, you have a aortic valve there, you have the right pulmonary artery and left pulmonary artery. Again, you see a continuous flow there. Okay, what is that continuous flow? So that continuous flow is again a pattern ductus arteriosus. So this is the theme that we will see over and over again when we talk about congenital heart disease, because they always need pulmonary circulation. Now, this is one of the very important view in congenital heart disease. This is called subcostal bicaval view. So normally in adult, we only see this in transesophageal echocardiogram. However, in children, we can also get this subcostal bicaval view. I have already annotated from you. That is the superior vena cava, that is the inferior vena cava, that's the right atrium, and that is the left atrium there. So as you can see, this is a septum. You can see obviously there is the secundum ASD that we see just now. This view is also special because this is one of the very little view that we can actually see superior or inferior sinus venosus ASD. So this patient does not have. So I just wanted you to be aware of this view that we can see. This is just to show you the subcostal view of the same patient with complete AVSD. So that's the left ventricle and right ventricle here. And you can see that the left ventricle come out to the aorta. So this show you quite vividly why the patient with AVSD have susceptibility to develop left ventricular outflow tract obstruction. So as you can see, that is the inlet portion from the left atrium to the left ventricle. It is significantly shorter compared to the outlet portion from the left ventricle to the aorta because of the unwaging of the aortic valve. So that is another reason that you can have LVOT obstruction. So I just wanted to show you again the common AV valve for this patient. Look at the common AV valve. So that is there. That is the superior bridging leaflet. That is the inferior bridging leaflet. If you can see, the superior bridging leaflet is actually divided in the middle. So this is again Rastelli type A. So another way to differentiate in terms of the size of the left ventricle and right ventricle to decide whether it's hypoplastic or not. So in this view, you can actually trace the area of the left ventricle. You can trace the area of the right ventricle, and you can see the ratio between the left ventricle and the ratio of all the ventricle. And a certain ratio denotes LV dominant, RV dominance, or balanced ventricle. So this is a mid separation of superior bridging leaflet or Rastelli type A. So I have shown you example of ASD primum and also example of complete atrioventricular septal defect. And the main thing that actually a basic of all those different type of atrial septal defect. If after surgery of someone with primum ASD or complete ASD, what is the common complication that we can anticipate if we see them in clinic? Number one, I already tell you already, this patient usually can develop cleft left AV valve. So they very commonly develop recurrent left AV valve regurgitation. So beware of those when you follow up the patient. They also can develop left ventricular outflow tract obstruction because of elongation LVOT or anomalous insertion of the chordae tendineae. So remember to look at that when you follow up the patient. They can develop complete heart block as well. So we have finished our ASD primum and AV canal defect. Okay, if you still don't understand, you are welcome to ask me at the final of our talk. What about ASD secundum? So again, look at this basic picture of the left ventricle, left atrium, and right atrium. Now, the main problem with ASD secundum, funny enough, is actually deficiency in the wall of membrane primum. So this is your membrane primum, but the deficiency is so big. So this ostium secundum, the second opening is so big, such that the membrane secundum is not able to cover this deficiency. So you are not able to cover the deficiency, therefore you got a secundum atrial septal defect. So one more time to make you understand it, this is the membrane primum, remember? And there will have an opening here called ostium secundum, the second opening. Usually the second opening, the ostium secundum is small, such that it can be covered by the membrane secundum. However, in ASD secundum, this deficiency is so big to such an extent that it cannot be covered by the membrane secundum. So you have a hole between the left atrium and the right atrium. So this is ASD secundum. So this is the most common of atrial septal defect. It happens in 75% of all atrial septal defect. So just to remind you that ASD causes right-sided volume overload. Because the right heart tolerates volume overload very well, it can take a long time for the patient to be diagnosed. How come ASD is not diagnosed when you were born? Because ASD usually does not cause murmur. VSD causes a loud murmur. Second, ASD causes pulmonary hypertension, but it causes less common pulmonary hypertension and it causes pulmonary hypertension later. Ventricular septal defect and PDA cause earlier pulmonary hypertension. Why is that? The reason is, if you remember that ventricular septal defect, it has shunt between the left ventricle and the right ventricle. The flow happens during systole. So as the left ventricle and right ventricle contract, the flow between the left ventricle and right ventricle happen. But because it's during systole, it doesn't go into the right ventricle, it goes straight to the pulmonary artery. So you are susceptible to pulmonary hypertension. Furthermore, because it bypasses the right ventricle, it goes to the pulmonary artery, it goes then straight to the left side of the heart. Therefore, in VSD and PDA, you have left-sided heart dilatation. So as I told you, the ASD secundum happened, surprisingly, not because of deficiency in membrane secundum, but because of deficiency in membrane primum. So this is a good trick question to give. It is the only ASD that can be repaired via transcatheter occluder device. So this is the gold standard or the first line therapy. All right, so it causes right-sided volume overload, and right-sided volume overload causes paradoxical septal motion. And paradoxical septal motion refers to the septum that is flat during diastole and that is rounded during systole. So this is paradoxical septal motion. If it's flat during systole and diastole, it is right ventricular pressure overload. Volume overload is flat during diastole and rounded during systole. 10 to 20% of patients with ASD secundum have an associated mitral valve prolapse. ECG typically show right bundle branch block with right axis deviation. So this is an example of ASD. So this is your secundum ASD there. ASD secundum is unique. It is the only ASD that is covered all the border by the atrial septum. Okay. What is the indication of closure of atrial septal defect? So the rest of the ASD you need to close regardless of the size. But for ASD secundum, any signs of right-sided dilatation or pulmonary hypertension, you close the ASD. Any ASD that is more than 1 centimeter, you close the atrial septal defect. And this is also useful in terms of prevention of atrial arrhythmia and stroke. What is the contraindication in terms of transcatheter closure of ASD secundum? Number one, ASD that is too big. So the Emplazer device only can accommodate maximum 4 centimeter diameter. So if it's more than 4 centimeter diameter, you cannot close transcatheterly. Number two, you'll have to look at the rim. What do I mean by the rim? In order to push and plexer device, that implexor need to catch on the rim of this deficient, of this atrial septum. If there's not enough rim, then you cannot put your implexor device. So you have to have enough rim on all the place except for the anterior rim, in which you might have deficient rim and you can still put the ASD occluder. What about physical exam in ASD secundum? So you can see the right ventricular lift. You can see pulmonary outflow murmur secondary to increase in pulmonary circulation. I just wanted to remind you, QPQS calculation in echocardiogram is not reliable. So if you want to do QPQS, better do it in cardiac MRI. So I don't use QPQS from echocardiogram. The patient can have fixed split S2 sound. They can have tricuspid regurgitation murmur. And this is what I said, it's not advisable to calculate QPQS with echocardiogram. Show you an example of ASD secundum. This is 35 years old lady with palpitation. So again, you can see that the left atrium and the right atrium, the left ventricle and the right ventricle, that's the left atrium and right atrium. And you can see an echo dropout there. Okay, always be sure that this is not just an echo dropout. So make sure that you can see the color flow through it, and make sure that to look at multiple windows. So very common in this apical 4-chamber view, you can see an echo dropout that not actually ASD. So in this patient, however, it is a true ASD. And you can see also there is an inferior border and superior border. So this is not an ASD primum. Yeah, that is the ASD there. So this is the AV border and that is the posterior border. Okay. So this is the AOPA view. So this is also a good view to look for ASD because this interatrial septum, it is not directly parallel to the insonation. So that's the left atrium, that is the right atrium, that is the right ventricular outflow tract. So again, you can see what seems like an echo dropout here. You have to demonstrate that the color flow from left to right. Okay, so this is another patient. This is the same patient. So the first is 4-chamber view, and this is AOPA view showing your ASD secundum. All right. So that's the ASD secundum there. This is the anterior posterior border. So whenever you see an aorta, that is actually an anterior border of the secundum ASD. All right. So this is one of the nicest place to look for ASD is subcostal 4-chamber view. So that's left atrium, left ventricle, right atrium, and right ventricle. So that is the interatrial septum. What is this nice? This is nice because the interatrial septum is perpendicular to the angle of insonation. If it's parallel, if it's easy to see, if it's parallel, it can be echo dropout. But because this is perpendicular, this part here is very unlikely to be a normal, just a normal dropout. So this is a real ASD secundum, as you can see with a left to right shunt. How do I know this is a left to right shunt? Remember when you look at echo, B, blue is away from the probe. So any blue is a flow away, so the probe is there. Any blue is a flow away from the probe, and red is a flow towards the probe. Okay, they call it BART, the mnemonic, B-A-R-T. Blue is away and red is towards. So as you can see, a lot of red flow towards the transducer. So this is left atrium, right atrium. The red flow is towards the transducer. So this is an example of secundum ASD with left to right shunt again. Okay. Let's see another example here. So maybe you can tell me straight away, what do you see here? So this is someone with a huge right side heart, left atrium, right atrium, left ventricle, and right ventricle. So what you can see here, you can see a huge right atrium. You can see that the septal leaflet actually too apical. So normally it must be apical, but only a little. But this septal leaflet is too much apical. Okay, so the septal leaflet is not properly delaminated. This anterior leaflet, anterior leaflet is elongated. Okay, so this is an example of Epstein anomaly. So this is your atrialized right ventricle. Now, if you look at the bottom view here of the same patient, you can see there is a flow. This is the echo dropout here. And you can see a flow across this echo dropout there. All right. And you can see that this is a red flow across it, and red is towards the transducer. So the patient also have Epstein anomaly because of failure of delamination of septal and anterior leaflet. And you also have ASD with left to right shunting. Okay. Now ASD causes right-sided volume overload, not pressure overload. So if you look at this pulmonary artery pressure, it is elevated, but it's not so high. Okay, this is an example of someone with Epstein anomaly and also ASD Secundum with left to right shunting. Okay, so I hope I show you how is the development of ASD secundum embryologically and how to see ASD secundum in echo, what is the indication for transcatheter closure and what is the contraindication of transcatheter closure. When you do TEE, sometimes you need to look at the rim. So what do I mean by the rim? So this is an ASD secundum here. You wanted to make sure that all the rim are sufficient so that your emphysema can grab into this hole. So what is the rim? So you have anterior, posterior rim. So in TEE, the anterior is the aorta. So whenever you see the aorta unfast, you are at anterior, posterior. Your bicaval view is superior vena cava and inferior vena cava. Your TEE four-chamber view is AV junction and posterior. So that is all your rim. So all of these rim need to be present, at least more than 3 millimeter, except for anterior rim. So anterior rim, is it okay if it's division? You still can proceed, but the rest it is not okay. Right? So anterior, posterior in TEE, AV posterior and superior inferior. So when you analyze ASD in TE, you have to make sure that you go through all these points. So this is the example. So if you look at here on the top right, this is the anterior posterior. Why anterior posterior? Because this is the AV valve. So this must be posterior. In this picture, you can see that the AV valve, there is not enough ring here. That is okay, all right? We only need rim at others, but not the AV. This is posterior rim. If you look from here to here, this is AV and posterior. So this is when you push your probe straight away, mid-esophageal four-chamber view. This is the AV rim. This is the posterior rim. What about this one? So this is a special view. This shows the view of your SVC and your coronary sinus. So this one is not necessary, okay? And this one is the bicaval view. So SVC, SVC, and IVC. This is the SVC rim, and this is the IVC rim. Again, anterior posterior rim, AV posterior rim, and superior inferior rim. And look at the ASD, right? So this is an example of patient have ASD here, so that's ASD. So this is left atrium, and that is right atrium. Sometimes you can see a structure here when you do TEE. Don't worry about that structure. That structure there is a crista terminalis. That structure here is crista terminalis. Don't worry about that. You can also see structure opposite, that is eustachian valve. This ridges here is actually your pectinate muscle in your right atrial appendage. So we have talked about primum ASD. We have talked about secundum ASD. Now we go through the most complicated one for me, which is a sinus venosus ASD. Now, sinus venosus ASD, it is not a true atrial septal defect. It is a deficiency of infolding of the atrial wall in the environs of the SVC. So SVC and left atrium actually share a wall. So if this wall is deficient, then you have a connection between the left atrium and right atrium through that deficient wall. It found within the mouth of either the SVC and IVC, but the IVC is exceedingly rare. It causes shunting between the left atrium and right atrium. It causes an extra cardiac but interatrial connection. The problem with sinus venosus ASD is, of course, it almost invariably is associated with anomalous drainage of the pulmonary vein. Now, anomalous drainage of pulmonary vein give problem to everyone because you cannot, it's difficult to think about it, so I make it easier for you. Now, during embryological development, you have 4 pulmonary veins that go into a common chamber that is called common pulmonary vein chamber. Now, this chamber should incorporate into the left atrium. Everything should incorporate into left atrium. Otherwise, if all of this doesn't incorporate to the left atrium, you have total anomalous pulmonary venous connection. Okay. However, more commonly, some of the pulmonary vein go into the left atrium, but some of the pulmonary vein doesn't go into the left atrium and it goes somewhere else. In patients with sinus venosus ASDs, especially, 2 of the pulmonary vein, the right upper and the right hollow pulmonary vein, rather than go into the left atrium, it like to go into the right atrium. So it doesn't go to the left, it bypass into the right atrium. So that is the anomalous drainage of the pulmonary vein. As I told you, there is also inferior sinus venosus ASD. So how do we suspect sinus venosus ASD? Suspect in someone with right-sided dilatation, but you cannot find the cause. Remember, whenever we have right-sided dilatation, always ask ourselves the differential diagnosis. Is this pressure overload? Now, with pressure overload, for sure you can see high pulmonary artery pressure from tricuspid regurgitation. You can see interventricular septum that is flat during both systole and also diastole. And you also can find the cause, maybe left-sided heart disease, so on and so forth. If it's not pressure overload, then it must be right-sided volume overload. Now, with volume overload, you might ask yourself, is there any problem with the tricuspid deflate? Is the tricuspid deflate fail or prolapse, for example? Does the patient have Epstein or does the patient have carcinoid disease? Now, if the patient doesn't have such problem, does the patient have chronic atrial fibrillation? Also, no. Does the patient have congenital heart disease, for example, someone with correction tetralogy of Fallot? Also, no. Then we need to go through ASD. Rule out ASD Secundum, rule out unroof coronary sinus, rule out Primum ASD. Then if we have ruled out everything, and lastly, we have to rule out sinus venosus ASD. Remember that it's very difficult to see this in TTE. So this is a patient. So one of the only way that you can see sinus venosus ASD from TTE is from subcostal view. So this is a subcostal bicaval view. So that is the SVC there. That is the IVC, that is the right atrium, and that is the left atrium. So as you can see, this is the wall separating the superior vena cava from the left atrium. If this wall is deficient, you have a connection between the left atrium and the right atrium. And the same can happen in IVC as well. So that is where the deficiency happens. This is a transesophageal echocardiogram, bicaval view. You can see that is the left atrium and the right atrium there. So that is interatrial septum. You know that this part here is the membrane primum. Okay, if there is deficient there, that is ASD secundum. However, you can see that this deficient extend over the limbus of the interatrial septum. So that is the limbus of the interatrial septum there. So this is the SVC. So this is the wall that is deficient. So you have a connection between the left atrium and the right atrium because of deficiency of the wall that separate the SVC from the left atrium. Okay. Another thing is, normally your right upper pulmonary vein and right lower pulmonary vein, rather than draining into the left atrium, it's draining into the right atrium as well. So how do you do to correct this? The correction for sinus venosus ASD. So one of the correction is what we call a Warden procedure. So what is Warden procedure? So in Warden procedure, what they do is they actually close the defect. And at the same time, when they close the defect, they also tunnel the anomalous pulmonary vein back into the left atrium. So they close the defect with a pericardial patch. At the same time they close the defect, they also tunnel the pulmonary vein that is anomalous drainage back to the left atrium. I will show you a few examples. So this is a 27 years old. So this is important to realize because it can be asymptomatic like secundum ASD up to adulthood. We have seen a 27 years old patient. I also have a 71 years old patient with this. So he have dyspnea on accession. So when we do a transthoracic echocardiogram, you can see that the right heart is dilated. And again, whenever the right heart is dilated, always the question that we ask, pressure overload or volume overload, and try to find the cause. Okay, so this is parasternal long axis view, and you can see that there is no dilated coronary sinus there. Okay, so unlikely to be unroofed coronary sinus. We also can look for ventricular septal defect in this situation. This is apical four-chamber view. That's the left ventricle, left atrium, and right atrium. Okay, look at the attachment of the tricuspid valve is slightly apical to the mitral valve. That is normal. Okay, if this is here, then you have L transposition of great artery. Okay, that's normal. And the RV is still dilated. So you might think that this is actually an atrial septal defect. But remember, whenever this is parallel to the angle of insonation, you can have susceptibility to echo drop up. So make sure that you actually demonstrate a color. So this patient actually does not have atrial septal defect there. Okay, that is where normal ultrasound drop out. So that is not atrial septal defect. So again, I put a color and I can demonstrate that there is no color flow from the left atrium into the right atrium. I still don't have an answer why my patient have right-sided heart dilatation. So this is a subcostal view. So this patient have levocardia. So levocardia, so when we talk about cardia, we talk about the position of cardiac apex. A normal position of cardiac apex is towards the left side. That is called levocardia. If the apex is towards the right side, we call it dextrocardia. If the apex in the middle, we call it mesocardia. Okay, that is cardia, the position of the apex of the heart. This is different position. If let's say the patient have level position, that is the position of the heart inside the thorax. So if the heart is on the left side of the thorax, that is called dextro position. Oh, sorry, on the right side of the thorax, that is called dextro position. Left side of the thorax is levo position, and the middle of the thorax, that is meso position. Okay, different between cardia and position. So this patient have levo cardia, that is good, and also AV concordant. What do I mean by AV concordant? Left atrium is connected to the left ventricle, and right atrium connected to the right ventricle. Again, this is a good view to see whether this patient have atrial septal defect, secundum ASD. Again, I can put a color here, and I demonstrate that there is no color flow throughout the ASD, so this patient does not have secundum ASD. So this is an AOPA view, so that is the left atrium, and right ventricular outflow tract. Again, I wanted to see whether there is atrial septal defect. I want to see whether there is a flow from the left atrium to the right atrium. So I put a color, so there is no flow from the left atrium to the right atrium. Again, I actually rule out secundum atrial septal defect. So this is not secundum ASD. This is not primum ASD. This patient, the same patient, you can see a membrane inside the left atrium there. Okay, so if you all know, so this is co-triatriatum sinister in the left atrium, and you by now should already know how to explain what is the pathophysiology. It is because the common pulmonary vein go inside the left atrium. However, the membrane separating the two is not fully resolved. So you have this co-triatriatum sinister in this patient. So what we do is, in this patient, we do a subcostal bicaval view. However, the window is not so good. We see IVC there. We can't really see a proper SVC. There is right atrium. The left atrium is possible there. There is a suggestion of a deficient here at the junction of the SVC and the right atrium and the left atrium. So we put a color. And when we put a color view, you can see a turbulent flow going towards here. So look at the arrow. So that is actually a turbulent flow coming from the left atrium to the right atrium. So this is a very suspicious as superior sinus venosus ASD. So this is IVC, that is SVC. So what we do is we proceed with the transesophageal echocardiogram. So this is transesophageal intra-operation. So I just wanted to show you how the sinus venosus ASD look like at intra-op TEE. So this is your aorta. That's your mesoesophageal 4-chamber view. So that is right ventricle, right atrium. So this is the interatrial septum, and you can see all the way at the posterior side, you can see the sinus venosus defect there. So that is your sinus venosus defect here. All right. Now, go again. So, and I zoom view, you can see blue. So this is your angle of insonation. Remember that blue is away from the probe. So this is your angle of insonation. So blue is away. So the flow is actually from the left atrium to right atrium. So there is no reversal of flow. Okay, so the left atrium flow is between left atrium to right atrium. So this is a sinus venosus ASD again. So that is the wall that is deficient, that is shared between the SVC and the left atrium. Okay, so this is a bicaval view that all are familiar with. So that is the interatrial septum. That is the left atrium and right atrium. You can see again, this is the wall that is deficient between the SVC and the left atrium. All right. Now, normally what happens is that you will have an anomalous right upper pulmonary vein drain somewhere here at the vicinity of the superior vena cava. Okay. So always look at a different color flow than the red flow. So you have a red flow from here, from left to right. So what happens is we go to that is the deficient part. So we go to the next view. Okay, now when we go to next view here, we can see the flow from the left to right. So this is just an inverted flow. So that's the left atrium and right atrium. That is the interatrial septum there. Okay, flow from left to right. However, this is the SVC. Now, however, you can see there is a red flow going into the SVC. Red flow going into the SVC. So what is this red flow going into the SVC? So that is actually the anomalous drainage of the right pulmonary vein going into the superior vena cava. Right. So I'm showing you again the view, right? So this, if let's say you will have your TEE and you pull up your TEE into the upper esophageal, you can see the aorta and the SVC side by side. Now the SVC should be round. Whenever you see SVC that look like a teardrop here, always be suspicious of anomalous pulmonary venous drainage. If you look at the picture after this, you can see the difference. So this, as we see here, the color is blue, but you see this red color here, whereby the anomalous right pulmonary vein is draining into the superior vena cava. Okay, red flow from pulmonary vein into the superior vena cava. I also wanted to make sure that the left upper and left lower pulmonary vein drain on the correct position. So this patient, they do drain in the correct position. Okay, so let's summarize the patient. So this patient, 27 years old, come with shortness of breath. When we do echocardiogram, the right heart is dilated. We try to find the cause. It is not ASD secundum. It is not ASD primum. It is not unroof coronary sinus. When we do subcostal bicaval view, there is a suggestion of a defect of a wall shared by SVC and left atrium. And you can see the shunt coming from the left atrium into the right atrium. So we go to operation, and from the operation, when we look at the bicaval view, you can see that there is a deficient wall. You can see flow that is abnormal going from left to right. And remember, whenever we are dealing with sinus venosus, make sure that all the pulmonary vein is draining to the correct place, which is the left atrium. So in this situation, both left pulmonary vein drain into the left side, but the right pulmonary vein actually drain into the right side of the heart. So you need to correct that during the operation. Okay, I give you another example. This is a 2-year-old girl with failure to thrive. Again, you can see a parasternal long axis view with right-sided heart dilatation. Again, we have to ask question, what is the reason of right-sided heart dilatation? So this is subcostal view. So this is LA, LV, RA, and RV. I hope you understand already what I mean by levocardia. Apex is towards the left side. There is AV and VA concordant, and there is echo dropout here. Is there secundum ASD? So you have to find out. Now, this is another view. So left ventricle, left atrium, and right atrium. However, if you look at this view, you can see that the interatrial septum actually look intact. Okay, it actually look intact. So maybe there is no ASD after all, secundum ASD. There is definitely no primum ASD. So we go and put a color. We try to see whether there is color through the interatrial septum. It's difficult to see, but I don't think there is color through the interatrial septum. Right, so this is a subcostal bicaval view. So I show you this again and again because this is a not familiar view that we see as adult. IVC, SVC, right atrium and left atrium. Look at that eustachian valve. People got a myth that IVC is, the eustachian valve is mobile. The eustachian valve is actually quite immobile, usually quite tense. You see that? It's not very immobile. So IVC, SVC, LA, and RA. So we try to see whether there is any shunt going from the LA through RA through the border, but we can't really see any shunt between the LA and the right atrium. So this is again a subcostal view. And again, we wanted to see whether there is any shunt. There is no shunt between the left atrium and the right atrium here. So at first, when the echocardiographer looked at echo, they thought the patient have secundum ASD, okay, because of the dropout. But remember, I told you, look properly, and it turned out the patient does not have secundum ASD. Now, but luckily, when the patient go for intra-operation, so this is intra-op, okay, so this is a bicaval view, but it's actually inverted. So this part here is IVC, that part here is SVC. Now you can see a deficient wall here. So you can see a deficient wall here, just at the border of IVC to the right atrium. You can also see a blue color flow from the left atrium to the right atrium here. So lo and behold, this patient, rather than having secundum ASD, actually have the very rare inferior sinus venosus atrial septal defect. You look at different view here, that's another different view. Okay, again, this is the SVC. Going down towards here is the IVC. That is the deficiency here between the left atrium and the right atrium. So in summary, turned out this patient have inferior sinus venosus ASD. Surprisingly for this patient, they don't have anomalous drainage of pulmonary vein. From earlier images, even though they seem like secundum ASD, this turned out to be a red herring. All that we see is echo dropout with no flow across the interatrial septum. So that is actually inferior sinus venosus ASD. So this is my last sinus venosus ASD case. So this is 71 years old with superior sinus venosus ASD. I go quickly, look at parasternal long axis view. Again, the right sided is dilated. This is subcostal view. That is the left ventricle, left atrium, right atrium. However, just right at the posterior here, you can see something deficient there. Okay, there is something deficient right at posterior. This cannot be secundum ASD. Why? Because there is no septal that is bordering it superiorly. Now we go to the next images. This is apical 4-chamber view, LV, RV, LA, RA, with a, you can see normal tricuspid valve attachment. Okay. So we zoom. Okay, and we wanted to see whether there is any abnormalities. So basically, this is your IVC here. This is subcostal view. Now, again, that is SVC. This is the LA, that is RA. Again, the same subcostal bicaval view. You see suggestion of a flow from the left atrium to the right atrium at the top here, suggesting superior sinus venosus ASD. Okay, so we go to intra-op TEE procedure. Okay, look at this. This is left atrium, right atrium. This is the interatrial septum. That is the superior vena cava there. And you can see blue. So this is the ultrasound insonation, blue flow from the left atrium to the right atrium. So this left to right shunt. What about red? So red here is the draining into the superior vena cava. So that is the deficient in terms of the wall shared by the left atrium and the superior vena cava. Now, I wanted to show you this image because this is interesting image where we do a 3D echocardiogram. So I have already annotated that is the left atrium, that is the right atrium. This is where there is deficient in the wall between the left atrium and superior vena cava, causing shunt. However, if you look in the middle here, you can see a hole here. What is that hole? So this is a beautiful illustration of the insertion of the anomalous pulmonary vein. The anomalous pulmonary vein actually insert into that hole there, into right atrium. Okay, so that is SVC, LA, RA, sinus venosus ASD, and the anomalous drainage of the pulmonary vein. Again, same patient. Okay, I just go a little bit higher, and again you can see that is the insertion of one of the pulmonary vein. That is insertion of another pulmonary vein, and this is the deficient wall between the left atrium and superior vena cava. All right, so I hope I have given you 3 cases of sinus venosus ASD. It's not easy. I myself haven't really get my head around it, but I hope I give you an example. At least you have something to think about. If you look at pathological specimen here, you can see that this is the sinus venosus ASD and the insertion of superior vena cava, and you can see the anomalous drainage of the right upper pulmonary vein 1 and 2. So what they do in Walden procedure, they just cover this ASD, and then they cover the ASD, they also cover the pulmonary vein. So they reroute the pulmonary vein back into the left atrium. So the cartoon on the right side here show the Walden procedure. As you can see, they covered the anomalous pulmonary vein and the sinus venosus ASD together. They reroute back the pulmonary vein back to the left atrium. It is originally described in 1858 and comprises approximately 4% to 11% of ASDs. The basic principle of repair is redirection of anomalous pulmonary venous connection through the intra-atrial communication. So in the contrast to operative repair of secundum ASD, the surgical approach of sinus venosus ASD is more complex and carries the risk of stenosis of the SVC or pulmonary vein, residual shunting, and sinoatrial node dysfunction. So that's again showing you pericardial patch. That is anomalous insertion of right upper pulmonary vein. That is sinus venosus ASD. Now, let's talk a little bit about anomalous pulmonary venous connection. So remember, I tell you, the pulmonary vein can drain anomalously. Okay. Now, we can have partial. So 3 most common type of partial anomalous pulmonary venous connection is number 1, you can have right pulmonary vein anomalously drainage to superior vena cava. So that is 1. Okay. Number 2, that is very rare. You can also have your left pulmonary vein. Rather than going into the left atrium, it actually go back to the brachiocephalic vein and go to the SVC. So that is another part of anomalous pulmonary vein, partial. So you got right to the SVC, left to the brachiocephalic. Sometimes you can have a scimitar syndrome. What is scimitar syndrome? You usually like to ask this in echo jeopardy. So this is when your right pulmonary vein anomalously drainage to the IVC. Okay, so when it drains into the IVC, the vessel that drains into IVC, if you look at X-ray, it looks like a sword, the Turkish sword, that is called scimitar. So that is scimitar syndrome. There is also a situation where some of the pulmonary vein might drain to the coronary sinus or even to the right atrium, but this is rare. You just remember the basic of anomalous pulmonary vein. One partial anomalous pulmonary venous drainage is not associated with ASD. Usually you can leave it alone. Say if you have single partial anomalous drainage, or even you have two, unless you have right-sided dilatation. So this is an example of someone with anomalous drainage of left upper pulmonary vein. So what happened in this patient is the left pulmonary vein, rather than draining into the left atrium, so this is actually a red flow going up, actually drain to the vertical vein back to the superior vena cava. So this is the vertical vein there, back to the superior vena cava. I show you this next image. So this is a better image. So your left pulmonary vein go into the vertical vein, back into the superior vena cava, rather going back to the left atrium. So that's an example of partial anomalous. What about total? So total is when none of the pulmonary vein go into the left atrium. So they can go one or three. They can either go supracardiac. So when they go to supracardiac, they can go straight away to the superior vena cava, or they can go straight away to the left SVC. Now, it can also be infracardiac. So all the pulmonary vein can also go directly down to IVC or hepatic vein. It also can go intracardiac, meaning that all the pulmonary vein drain into either the right atrium or coronary sinus. However, luckily for us, patients with total anomalous pulmonary venous connection don't survive childhood. Usually they get operation straight after childhood. Once they see us, they usually already operated upon. Okay? And this total anomalous is actually an integral part of isomerism of right atrial appendage. If you remember what is isomerism of right atrial appendage, it is when both atrium is actually a morphological right atrium. Okay, so this is logical because there is no left atrium for the pulmonary vein to connect to. Okay, so I hope you have understand the difference between partial anomalous pulmonary venous connection and total anomalous pulmonary venous connection. So this is an example of scimitar. So what happened is that all of your right pulmonary vein now connect to the IVC. So you see this shadow here going from top down that look like a sword. So that is what we call scimitar or scimitar syndrome. So another one that I wanted to show you, something that might be useful for exam, this is what we call a snowman appearance in X-ray. So this is when you have a total anomalous pulmonary vein connection going to the vertical vein, to the brachiocephalic vein, and to the right superior vena cava. So there's example of someone with anomalous pulmonary vein drain into the IVC. So that is the IVC. So this is the IVC, that is the anomalous pulmonary vein there. So this is another example of scimitar syndrome in echocardiogram. All right. Now we almost finished. We will have just one more atrial septal defect to go for. Sorry, there is a lot of embryology, so, but it is important to understand. Okay. So this picture here is embryological development of our cardiac, of our vein or our cardiac venous development. If you remember, this is our primordial atrium. Remember, this will develop and become left atrium. The left side of sinus venosus will actually become our coronary sinus. The right side of sinus venosus will actually become our right atrium, the smooth part of our right atrium. Now, if you look at this part of the heart here, this is actually what we call a right anterior cardinal vein, and this is a left anterior cardinal vein. So this developed into this. So what happened here? So what happened is that you will have your left atrium and your right atrium. The left side of the sinus venosus has become the coronary sinus. The left anterior cardinal vein usually disappear. Okay, if this left anterior cardinal vein does not disappear, that becomes your persistent left superior vena cava. Okay, you should only have a right superior vena cava. So this is how your left superior vena cava can come about. So the left one sinus venosus, remember, become the coronary sinus. The right become the smooth wall of the right atrium. The left anterior cardinal vein will disappear. It persists, it becomes persistent left SVC. The right anterior cardinal vein will become a normal right SVC. The right vitelline vein here will become the inferior vena cava. All right. If you were to have left superior vena cava, what happens is that you can have both superior vena cava not connecting to each other. You can have both superior vena cava connecting to each other via innominate vein here. All right. Why is important to understand persistent left superior vena cava? Because it is almost invariably unroof coronary sinus is almost invariably associated with persistent left superior vena cava. All right. So this is the teardrop SVC that I told just now for patient with partial anomalous pulmonary venous connection. So this is the SVC should be circled, but you see a teardrop. When you look at the next echo, you can see that the red flow going towards the SVC, so that is the anomalous drainage of the pulmonary vein. So last one, okay? So this is ASD, unroof coronary sinus. It is the deficiency of the wall between coronary sinus and the atrium. This is an inter-anterior communication through the mouth of coronary sinus. At its most extreme form, a left SVC connect to the roof of left atrium. The entire wall of the coronary sinus is lacking, and the mouth of coronary sinus form a large communication. It is closely associated with persistent left superior vena cava. So how do I tell whether someone have unroof CS? Is very easy. Number one, they have dilated CS. So this is a parasternal long axis view. That is the left atrium, left ventricle, and right ventricle. All right, I just do slowly. If you look here, there is a round structure there, just adjacent to the basal infralateral wall. Okay, you see a round structure here. Okay, and if you see the round structure here, the round is actually not complete. As you can see, there is deficiency between the structure and the left atrium. So that is your unroof coronary sinus. Now, how do I want to make sure that it is unroof coronary sinus? It's not just unroof coronary sinus that is dilated because of some other reason. So the way to do this is like that. Unroof coronary sinus is invariably associated with persistent left superior vena cava. So what happens is you inject an agitated cell line into the left brachial vein. The agitated cell line will go into the left superior vena cava and will go into the coronary sinus. Then you see the coronary sinus bubble. Now, in patient that does not have unroof coronary sinus, the bubble will go to the right side of the heart only. If the patient have unroof coronary sinus, not only the bubble go to the CS, the bubble will also go to the left side of the heart. So I show you in this next images of someone that we put bubble on the left brachial vein. You can see the bubble go into the CS, then the bubble go into the left atrium, and the bubble go into the left ventricle, and also the right side of the heart. This shouldn't happen if the CS is roof. Only because it's unroof that the bubble can go to the left atrium and also to the left ventricle. Right? This is a picture. So this is an example of unroof coronary sinus here. All right. So unroof coronary sinus can be classified. This is the classification. You don't need to know this, but there is a classification. So type 1 is a completely unroof. Type 2 is unroof without left superior vena cava. Type 3 is partially unroof mid portion. Now, and type 4 is partially unroof terminal portion. So that is not important. I just wanted to pay attention to this apical 4-chamber view. Let's say I put a bubble into the patient left brachial vein now. Okay, so left ventricle, right atrium. Put a bubble inside the left coronary sinus. You can see that only the right side of the heart got bubble, but not on the left side of the heart. So in this situation, we know that this patient only have persistent left superior vena cava without unroof coronary sinus because there is no bubble escape to the left side of the heart. All right. So this is a persistent left SVC without unroof coronary sinus. If you look at the picture, I'll show you where the bubble goes. You and the picture, the cartoon. So the bubble go to the left brachial vein, go to the left superior vena cava, go to the coronary sinus, then it will shunted to the LA and to the LV, and also to the RA and RV. So the left side of the heart will be bubble. If there is no unroof CS, only the right side of the heart will be bubble. Okay. So that is the atrial septal defect for today. I hope you can understand. I know it's a bit complicated topic. The reason I make it this long is because I wanted you to understand the embryological basis of ASD. So let's go very quickly. ASD primum is an endocardial cushion defect. It is part of atrioventricular canal spectrum where all the patients have the same pathophysiological abnormalities, which is the deficiency of the atrioventricular septum, where the attachment of the common AV valve determine the type of AV canal, whether it is ASD primum, transitional AVSD with small VSD, or complete AVSD with a big VSD. I talk about secundum ASD. Remember, this is because deficiency in the membrane primum, so that your membrane secundum cannot cover the membrane primum that is deficient. Number 3 is sinus venosus ASD, which is the deficiency in the shed wall between SVC and left atrium, or IVC and right atrium. I told you about unroof coronary sinus and how to diagnose it with bubble. And also, we talk a little bit about what is partial anomalous pulmonary venous connection. Some of the pulmonary vein does not drain to the left atrium, or total anomalous pulmonary venous connection. All the pulmonary vein does not drain to the left atrium. So in summary, it's more exciting to learn about atrial septal defect when we have rough idea or embryology in terms of interatrial septum formation and also heart tube development. Out of the 4 ASD, only secundum is a true interatrial connection, and only secundum can be closed with transcatheter device. ASD primum is part of spectrum of AV canal defect. It is useful to remember that the common AV valve comprises of superior bridging, inferior bridging, left mural, right anterior, and right inferior leaflet. Sinus venosus ASD is associated with anomalous pulmonary venous drainage. And the unroof CS is the least common ASD and is commonly associated with persistent left superior vena cava. So I thank you for your attention. I have no idea how many of you that is left. Now, thank you for staying with me until long, and feel free to ask any question. Thank you very much.